for joining us locally. We're just gonna a few more minutes and we will start at 25 to 8. Just a few more minutes and then we will start. Today's presentation is on selective estrogen receptor modulator drugs, which are important drugs specifically that are important in the management of breast cancer patients. Also for us again, and we do get involved in management of breast cancer patients. It's also for infertilities and osteoporosis. I think those are your main conditions that these drugs are mainly used in, but we will look at one or two other conditions where they might play a role. Dr. Mkhize will be presenting this morning. Dr. Mkhize, over to you.
Good morning, everyone. I'm Dr. Mkhize. I'm supervised by Dr. Mkhize. I'm doing a topic, selective estrogen receptor modulators. So cover the background, introduction, mechanism of action, classification, and role, and specific effects of SEN. So just to go on the background, around 1900, hormone nature of ovarian control of female reproductive system was established. In 1923, a bioassay for alcoholic ovarian extract based on vaginal smear of a rat. And then in 1926, they found that the sex hormone varied in urine of women throughout their menstrual cycle. In 1929, an active estradiol was obtained in pure form. 1944, a high-dose estrogen was used for the first time for metastatic breast cancer. ES was then prescribed in 1938. For the first time, the non-steroidal estrogen was discovered in 1958. Then, around 1960, they demonstrated the presence of an intracellular receptor estrogen alpha in circuit tissues, and clomiphene was discovered for induction of ovulation. In 1966, the second receptor for estrogen was then identified, and it was termed estrogen receptor beta. In 1970, tamoxifen was used for metastatic cancer. Around 1980, tamoxifen was then approved for chemoprevention. Around 1987, selective estrogen receptor modulator was first described based on tamoxifen and raloxifene studies. A trial on raloxifene was done in 1994, and in 1995, co-regulators of estrogen receptor action were discovered. In 1998, raloxifene was approved for osteoporosis, and in 1998, again, breast cancer reduction was approved with tamoxifen. In 2007, raloxifene was approved for breast cancer reduction. So what are selective estrogen receptors? These are non-steroidal compounds that are capable of binding estrogen receptor and produce several responses ranging from pure estrogenic agonists to anti-estrogenic activity depending upon the type of tissue involved. Selective, as the name says, they block estrogen action in some tissues and activate estrogen action in other cells. Estrogen receptors are present in many cells in different tissues in our body, but each receptor is different in their structure. So breast cell estrogen receptors are different from bone cell estrogen receptors, and both of these estrogen receptors are different from uterine estrogen receptors. So there are two major forms of isoforms of estrogen receptors that govern a wide range of physiological processes, including the development of female reproductive system, maintenance of bone mass, and protection of cardiovascular tissue and central nervous system. And these are estrogen receptor alpha and estrogen receptor beta. The alpha is mainly found in the breast, hypothalamus, endothelial cells, and vascular smooth muscles, also found in the uterus, ovary, and vagina. Whereas the estrogen receptor beta is found in the prostate, bone, the heart, the intestines, the lung, the brain, the ovaries, adipose tissue, and the immune system. So both the estrogen receptor isoform contain, if you look at this picture, They contain domain A to F, which consists of an activation function domain, that just contains A and B, and the activation function 2, E and F, which facilitates the transcriptional activation of the receptor. So the A to F represent different domains of the estrogen receptor. The numbers actually indicate or represent the amino acids. The estrogen receptor consists of a DNA binding domain, which is C, which facilitates the estrogen receptor binding to the DNA, which I'll show you in one of the diagrams. So on the DNA, it binds on the estrogen response elements, the ERE, and on a hinge region D, which contains a nuclear localization signal. And this binds estrogen and estrogen analogs. All the receptors function as a ligand-modulated nuclear transcription factor. So the role of the estrogen alpha in cancer initiation and progression has been well established in breast cancer, while its role in ovarian and endometrial cancer is less well known. And the role of the estrogen receptor beta in all cancers remains unclear. Therefore, we'll only discuss estrogen alpha isoform as it refers to cancer as a target for anti-estrogens. So, as I said, all the receptors function as a ligand-modulated nuclear transcription factor. They are the members of a larger receptor class known as the nuclear hormone receptors. And all the nuclear receptors share the unique feature of being able to directly bind to the DNA, allowing them to act as a transcription factor. Other family members include the progesterone receptors, androgen receptors, glucocorticoid receptors, and mineralocorticoid receptors. And 17-beta estradiol is the most potent endogenous estrogen and highly selective estrogen receptor. So, as you can see in A, so A is the estrogen receptor alpha that I showed you initially. And then B is how, okay, so pretend as if you don't see these red crosses and there's no aromatase inhibitor. So when you look at the estradiol, so when estrogen binds to the ER receptor, which is this, it undergoes a conformational change resulting in its homodimerization. Okay, so which is this. So the ER homodimer then binds to the region of DNA here, called the estrogen receptor element that are present in the promoter of specific sets of target genes. The gene regulation occurs when the ER homodimer builds a transcriptional complex on the DNA with interacting proteins collectively known as co-regulators. So the co-regulator recruitment is dependent on the ligand-induced changes on the ER conformation in the position of several helices within the ER, most importantly the helix 12. These co-regulators can either activate, this is CoA, so activate, or it's inactivates the CoR, the ER transcriptional complex, thereby directly influencing the ER target gene expression. The ER target genes regulates proliferation and survival. So if this regulation, this pathway of ER signaling within the breast, ovary, and the uterine tissue has been implicated in the onset of cancer in these organs, has led to the investigation and development of anti-estrogenic therapeutic agents. So in estrogen receptor positive breast cancer, for example, active ER signaling drives proliferation, so it remains heavily pursued and exploited pharmacological targets. 75% of cancers are estrogen receptor sensitive, and in these, estrogen antagonists are used predominantly. Other inhibitors that are used on the ER pathway are categorized based on their mechanism of action. So which are those drugs that modulate the function of the estrogen function? So we have the estrogen preparations, which are natural, synthetic steroidals and synthetic non-steroidal estrogens, and we have the conjugated estrogens. On another group, we've got anti-estrogens, trimethoprim, which we'll discuss shortly. And then we have the selective estrogen receptor modulators that we are going to discuss intensively, hence our topic. Then we have the aromatase inhibitors, and we have our selective estrogen receptor destructors. So, for example, in estrogen receptor positive, again, we have the diagram. So in this, the same diagram, now we are bringing back these red crosses to explain what happens then if we use these drugs, the aromatase inhibitors, the SEMs and the SET. Like I've explained that this is the estrogen receptor alpha. So the AF domain constitutes the estrogen receptors. It includes the activation function domain, the AF1. Here it's a better diagram. AF1 domain, ligand binding domain, and the hinge region, ligand binding domain, the AF2. The effects of the endocrine therapies on the estrogen receptor pathway, for example, the aromatase inhibitors, prevent the ER signaling by inhibiting the synthesis of estrogen, as you can see here. So it doesn't even get to bind to the estrogen receptors, so gene transcription does not happen. And then the SEMs, on the second one, the SEMs prevent the ER signaling by binding to the ER and causing an inactive complex. And then the SETs prevent the ER signaling. Prevent the ER signaling by causing a degradation of the estrogen receptor, so it doesn't even get to bind to the DNA. So those are the different drug modulators on how they modulate estrogen receptors. So as an agonist, mechanism of action for the SEMs, as an agonist, it binds to the ligand binding domain. It is about the receptor dimerization and its interaction with estrogen receptor element. And then this gene transcription is promoted through certain coactivator proteins that I showed you, the CoA and the CoR. On binding an estrogen antagonist, the receptor assumes a different conformation and interacts with the core pressor protein, inhibiting the gene transcription. Again, even patients that are on SEMs, they can have cancer growth, hence we have the SEMs resistant cancers. So dysregulation of the process that I've showed you also does cause cancer growth. So how then do we classify the SEMs? The SEMs are classified according to their chemical structure into 4 groups. We have the triphenyls, we have the benzols, we have the phenyls, and the tetraphs. So under the phenyl, we have the tamoxifen and tamoxifen-like. The tamoxifen-like include the torimifene, doloxifen, and adoxifen. And under the benzols, we have raloxifen and azoxifen, which we'll discuss shortly. And under the phenyl, we've got the vasodoxifen, which we'll discuss below, and tetra, which is lasoxifen, which is noted to have a good oral bioavailability. It's potent in osteoporosis, but a poor intestine substrate is associated with endometrial hypertrophy. When we look at the tamoxifen, for example, it is known as a male contraceptive, and it is currently used to treat all stages of breast cancer, chemo prevention in women at risk of osteoporosis, and lipids in postmenopausal women. And then when we look at the tamoxifen-like, the doloxin, with adoxifen has been proven not to be superior to tamoxifen and does not have a better side effects profile than tamoxifen. Then we have the pipindofsifen that shows efficacy in tamoxifen-resistant tumors, but it was discontinued. And then the lasoxifen is also efficient in reducing the risk and severity of estrogen receptor positive breast cancer, but it is associated with endometrial hypertrophy. So the pharmacological role of SEMs is the osteogenic effect in the bone, the brain, and the liver. It also produces antagonist activity in the breast. It inhibits breast cancer cells but has an agonist, is an agonist in the endometrium, which is harmful. They are now being used as treatment for osteoporosis, breast cancer, and postmenopausal symptoms. Examples that are used in clinical practice include the tamoxifen, raloxifene, lasoproxifene, and bazedoxifene. In terms of safety, they are not used in breastfeeding women and in pregnancy. Basically, they are largely for treatment of different conditions associated with postmenopausal women health, including hormone-responsive cancer and osteoporosis. Generally, SAMs will reduce bone resorption, they will increase bone mineral density, and reduce the number and size of osteoclasts in menopausal women. So specifically in osteoporosis, we know that generally we use the HRT to prevent bone loss in our postmenopausal women and to relieve menopausal symptoms. But is it that what but we do not pay attention to the bad side of HRT when we compare to SAMs. So we normally use HRT as our first line, including the vitamin D and calcium. And then SAMs would use it ideally as a second agent. So the overall good and bad aspects of administering hormone replacement therapy to postmenopausal women compared to the observed site-specific action of SAMs, the tamoxifen and raloxifene on this picture. If you look at it, the HRT, the good and the bad, as much as HRT lower the hot flashes, reduce colon cancer, with no increase in endometrial cancer and reduce osteoporosis, but it's also bad in the sense that it increases Alzheimer's disease, reduces cognitive function, causes stroke, breast cancer, and increases DVT. And when you look at the SAMs, both the tamoxifen and raloxifene reduce both breast cancer. Raloxifene only reduces endometrial cancer, and raloxifene reduces osteoporosis. But the adverse effects are also there, which most of them increase the hot flashes. So they're not doing what the HRT are doing. They increase stroke as well. There's an increase in endometrial cancer and increase in DVT. So our reason for doing this presentation is to look at what is an ideal SAMs, what can cover all the side effects. So when we look at the raloxifene, it is known as a failed breast cancer drug and is the only SAMs approved internationally to be used for prevention and treatment of postmenopausal osteoporosis and vertebral fractures. So it has agonist effects on the bone and on the heart, and antagonist effects on the endometrium and the breast. In postmenopausal women, it prevents bone loss. It reduces LDL cholesterol, which is bad cholesterol, but there's no increase in the good cholesterol, HDL, and triglycerides. It also demonstrates efficacy in preventing breast cancer since 2007. Like I highlighted in the background, and it significantly reduces the risk of estrogen positive or receptor positive breast cancer. It does not increase uterine proliferation, so the patient is not at risk of endometrial cancer, which I don't see them. It's not used for menopausal vasosymptoms because it causes hot flashes. So the side effects include hot flashes, leg cramps, pelvic bleeding, and increase in DVT. It's contraindicated in breastfeeding, pregnancy, and thromboembolism. The use of a dose of 60 milligrams a day. Like I said, the main groups or the first line would be the calcium, vitamin D, HRT, and biophosphonates, and then SAM as a second line. It reduces the risk of vertebral fractures by 10 to 50%, used for treatment and prevention of postmenopausal women who cannot tolerate the biphosphonates, or women that are at increased risk of breast cancer. So looking at the combination therapy, biphosphonates and raloxifene are not recommended to be used together as the benefit is small. And the disadvantage is that after stopping the drug, there's no prolonged effect. It's also not effective in treating premenopausal women, osteoporosis in premenopausal women. Instead, it has the opposite effect. It also displays a cross-resistance to tamoxifen-treated tumors, and only shows modest efficacy in advanced breast carcinomas. It is taken orally, hence it has a very poor bioavailability. So for that reason, they looked at the azoxystrobin, which is a better alternative due to its better bioavailability. It also causes breast cancer inhibition, which was comparable to tamoxifen and even greater than raloxifene. So the azoxystrobin has also had a better endometrial profile, just like raloxifene in the same group. But it was found not to be as effective as tamoxifen in tamoxifen-resistant breast cancer. So azoxystrobin in the same group as raloxifene remained inferior to tamoxifen, and it was terminated because of the time progression endpoint. So in terms of potency, it's less potent than alendronate and estrogen. Therefore, it's used as a second agent for prevention and treatment of osteoporosis. And then in another group, we have the bazodoxifene, which was thought to display SAMs, which was thought to be a SAMs, but it displays cells-like profile, which are the selective estrogen receptor disruptors, defined by its distinct gene regulation in the estrogen receptor alpha 10 over. Hence, it's often referred to as a mixed SAMs and SAMs hybrid. So, bazodoxifene binds to estrogen receptor with high affinity and acts as a potent antagonist inhibiting estrogen-induced proliferation. And in Europe, it is available as a monotherapy for prevention and treatment in osteoporosis. And in the US, it's available in combination with the conjugated estrogen for preventing of vertebral fractures. And in South Africa, we don't have it. So it has the same efficacy as raloxifene, mainly for tamoxifen-resistant cancers. It's ideal in women with intact uterus and hot flushes. The combination therapy decreases the side effects, which only Europe has. So it decreases vaginal dryness, hot flushes, and endometrial cancer. But unfortunately, the side effects is still DVT, stroke, and muscle cramps. It's contraindicated in DVT, breast and uterine cancer, liver disease, and PPD. And on the cardiovascular system, like I did say, that it's an agonist in the bone and in the heart. The SAMs will decrease the LDL, which is good in postmenopausal women. And some SAMs, the tamoxifen-like, increased the HDL and decreased triglycerides in postmenopausal women, breast cancer patients. And when you compare them to estrogen alone, or estrogen replacement rather, they increase the HDL and lower the triglycerides and lowers the LDL, which is still quite good. Then we go to the tamoxifen, which is I did say it's a failed contraceptive currently used in all stages of breast cancer and chemo prevention in women at risk, osteoporosis and lipids in postmenopausal women. So it's mainly used for primary breast cancer, both early and advanced, used for both pre and postmenopausal women as adjunct therapy. It's also used for male infertility, used for McCune-Albright syndrome and gynecomastia. The side effects include the hot flashes, PV bleeding and discharge, menstrual irregularities, thromboembolism, and uterine cancer. Ovarian cysts in premenopausal women, and hepatic enzyme changes. It's contraindicated in pregnancy, so if it's used in premenopausal women, which is usually is, pregnancy should be excluded. Then for women that do experience a lot of hot flashes in this group, SSRI specifically, the venlafaxine should be used. Not that all the other SSRIs are not recommended. Drug interaction is SSRI, except the one we can use for the hot flashes. The dose is 20 to 40 milligrams per day. When compared to the other SAMs, it has been superior equivalent side effects. None of the groups have been proven to have a better profile. Duration is 5 to 10 years, and 10 years has reduced risk of breast cancer recurrence and related mortality. So if you use it longer, the better. So the specific effects, in summary, is that SENS and estrogen-like effects increase the risk of blood clots, increase hot flashes and leg cramps. As an agonist in the uterus, it increases the risk of uterine cancer. As an antagonist in the breast, it reduces the risk of breast cancer. An estrogen agonist in the liver, it lowers the LDL cholesterol and raises the HDL cholesterol, which is what we want. And then estrogen agonist in the bone, it inhibits bone resorption and reduces bone loss. So what if you have a patient that presents with abnormal uterine bleeding on tamoxifen? For premenopausal patients on tamoxifen, they do not carry the same risk of developing endometrial cancer as postmenopausal patients. That's why tamoxifen is an ideal drug for them. So if you do see them, you must take an appropriate history, establish their menopausal status. The drugs that are commonly used, the tests that are commonly done is the transvaginal ultrasound, endometrial biopsy, saline infusion sonography. If you think there's an anatomical pathology, can be used, and then the DNC. For premenopausal women, an office endometrial biopsy can be done, and the transvaginal ultrasound can be done if endometrial pathology is suspected. So if they are bleeding, but they've got a allergy that you can treat, or something that is causing them to bleed. For example, if they've got polyp, you can do hysteroscopic polypectomy. And if they've got endometrial hyperplasia, so it's different for postmenopausal women and premenopausal. So for postmenopausal, hysterectomy is the definitive treatment. The role of progestin is not clear for postmenopausal women on tamoxifen. Then in women who are premenopausal and they are on tamoxifen for chemoprevention, there is a role for progestin. You can give them Mirena and Velileta, discontinue tamoxifen, and offer hysterectomy if they've completed their family. But if they are on the tamoxifen for adjuvant breast cancer therapy, you can just monitor them, close observation, you do their serial endometrial biopsies, and ideally you'd want to see endometrial hyperplasia without atypia. If it's with atypia, then it's a different ballgame altogether. Then you can offer them hysterectomy. Then in women who present with the AUP vein, but without any anatomical pathology or pathology at all, then you can offer them hysterectomy as treatments. The Mirena is only for premenopausal patients on tamoxifen, not for breast cancer. All patients on tamoxifen should undergo routine gynecological exam, and we counsel to report any symptoms. American College of Obstetricians and Gynecologists recommend against the screening of asymptomatic patients, but screening before initiation of proposal women on tamoxifen. Then we touch on a bit on the breast cancer. Endocrine therapies prolong the survival of estrogen receptor positive and delay the need for chemotherapeutic intervention. So 3 classes have been used, which is the SENS, and the aromatase inhibitors. So tamoxifen is used as an adjunct therapy and can be used for up to 10 years. It has shown to reduce incidence of breast cancer recurrence in premenopausal women with advanced estrogen receptor positive, ovarian suppression either by ovariectomy or radiotherapy or LH antagonist with the tamoxifen is recommended. So it's used together. And then in postmenopausal women, aromatase inhibitors are recommended or preferred. Then we have the sets. We'll just touch on this one particular one. We have 5 others, which we will not talk about today, but we will talk about this full strength, which is also a SAD. In contrast to the SANs, these are anti-estrogens that are designed to destabilize the estrogen receptors and function by binding to and inducing the degradation of estrogen receptors, thereby inhibiting the dimerization, abolishing the estrogen signaling pathway. The SANs are anti-estrogen. Like I said, they degrade estrogen receptors. They have better kinetics than estrogens. They are useful in tamoxifen-resistant tumors. That's why we have to include them, because of its antagonism action. It inhibits the ER and the progesterone levels. So despite a large percentage of tamoxifen-resistant cancers displaying across resistance to other SAMs, it has come to light that these cancers still heavily engage the ER signaling axis and continue to rely on the growth pathways mediated by the receptors. The fact that the ER signaling pathway remains active, it could be explored with this drug. So it is mainly used for advanced breast cancer that progress regardless of other treatment modalities. So this is the trade name, and the dose is 250 to 500 milligrams IMI. 500 milligram being an ideal dose according to a few trials that were done to evaluate if a smaller dose, which is 250, is ideal of 500. Currently, there's no oral formulation. And these are other sets that are currently under investigation. So the breast cancer is also diagnosed, it's usually diagnosed in early stages. So treatment normally involves surgery followed by adjuvant therapy. The adjuvant therapy is mainly to prevent the progression of micrometastasis or any dormant lesion to prevent recurrence and reduce mortality. Whereas in advanced metastatic estrogen receptor positive, anti-estrogen remain the mainstay of treatment. Whether used alone and in combination with targeted agents, and endocrine therapies can be used to prolong survival and delay the need of chemotherapy. So the key difference between these terms to be used for breast cancer is their safety and their endometrial safety. So a new approach to reduce breast cancer is the development of aromatase inhibitors. When treating early-stage hormone receptive positive breast cancer, aromatase inhibitors have more benefits and fewer serious side effects than tamoxifen. So as adjuvant therapy, aromatase inhibitors have been studied and demonstrated a clinical benefits compared to tamoxifen in postmenopausal women. So it is used as a preferred first line of tamoxifen in advanced estrogen receptor positive cancer, as it decreases estrogen synthesis, as I've shown you in that first diagram. It does this by inhibiting aromatase enzyme complex in the steroidogenesis. So the impact study, which is immediate pre-operative anastrozole, tamoxifen, or combined with tamoxifen, study concluded that aromatase inhibitors can be used alone, before or after the tamoxifen. And aromatase inhibitors are better alternative to inhibit the overexpression of estrogen receptors. Also, the National Comprehensive Cancer Network guidelines recommend that the aromatase inhibitors can be used as an adjunct therapy. Tamoxifen, you can use tamoxifen for 5 to 10 years, or use aromatase inhibitors for 5 to 10 years. We use the tamoxifen for 5 years, followed by the aromatase inhibitors for 5 years. Use tamoxifen for 2 to 3 years, followed by aromatase inhibitors for 5 years, and aromatase inhibitors for 5 years, followed by tamoxifen for 5 years. Similar to postmenopausal women, premenopausal women should receive at least 5 years of adjunct tamoxifen with ovarian ablation or suppression. So if we use it for the premenopausal women, these women should be examined for their menopausal status after 5 years of therapy. If they are menopausal after this period, then they're given a choice to either stay on the tamoxifen or be changed to aromatase inhibitors. In early stage disease, they can stay on the tamoxifen for 10 years. This is for both peri and premenopausal women. Then in premenopausal women, tamoxifen is preferred with the use of ovarian ablation for rectal radiotherapy or a LH-releasing hormone antagonist over aromatase inhibitors. For chemoprevention of breast cancer, raloxifene is approved for use in women with intact uterus with a high risk of osteoporosis, whereas tamoxifen is preferred in women without the uterus. And then the use of SERMs for other types of cancers. In ovarian cancer, 90% of ovarian cancers are epithelial in origin and express the estrogen receptor. Therefore, they can promote the proliferation and migration of ovarian cancer cells, and anti-estrogen can reverse this. In one study by the gynecology group, where patients were given tamoxifen for persistent or recurrent disease, demonstrated a complete response in 10 to 18% of these women. Another study was a mid-Atlantic oncology program where tamoxifen versus other hormonal agents also concluded that anti-estrogen therapy might be useful in the long-term palliation of chemo-resistant ovarian cancer patients. Then another one compared tamoxifen versus chemo in platinum-resistant ovarian cancer. And this showed a progression-free survival of 8.3 weeks for tamoxifen and 12.7 weeks for chemotherapy. And there was no difference in overall survival between the two. Toxicity was obviously higher in the chemo group compared to tamoxifen, and those who had chemo also had a poorer quality of life. The tamoxifen was also used in those patients with biochemical relapse of ovarian cancer. These are patients with an increase or increasing CA125, but they are asymptomatic. In endometrial cancer, type 1 endometrial cancer is the only one that's estrogen receptor positive, but has a better prognosis compared to type 2, which has estrogen receptor negative. Data is scarce for the use of in endometrial cancer, though the science has shown a small benefit, but more studies are needed. So this is just a summary of what we've discussed between tamoxifen and raloxifene. On the breast, the tamoxifen is an antagonist, reduces cancer risk in pre- and postmenopausal women. The raloxifene is also an antagonist in the breast, it reduces cancer risk in postmenopausal women specifically. In cholesterol, it reduces tamoxifen reduces LDL. Just like raloxifene in bones, the tamoxifen is an agonist, increases bone density in postmenopausal women, does not reduce fracture risk though. And then the raloxifene becomes a better drug. It increases bone mineral density by 2 to 4% and reduces incident of new vertebral fractures by 30 to 50%. And in the uterus, the tamoxifen is a partial estrogen agonist, increases the endometrial thickness. And the good thing with raloxifene, it does not increase endometrial thickness. So it's an estrogen antagonist, not an agonist. Then on the liver, tamoxifen is an agonist. It's taken orally. It has a half-life of 10 hours, up to 7 days, excreted in the bowel. And then the raloxifene is an agonist taken orally. It has an extensive first pass metabolism and half-life of 28 hours. It's excreted in the feces. Then we thought we should touch on the clomiphene as well, as much as it's not under the classification of selective estrogen receptors, but it also has estrogenic and anti-estrogenic properties. Its mode of action is in the hypothalamus, where it inhibits the negative effects of estrogen on the hypothalamus, inducing the release of gonadotropin, which leads to the development of maturation of ovarian follicle. It's indicated for management of ovulatory and oligo-ovulatory infertility in patients with intact HPO excess. Hence, it's used in male infertility and IVF. So it's taken from day. It's taken from day 2 to 5. It's metabolized in the liver, excreted in the feces via the bile. Contraindicated in liver disease, ovarian cyst, and abnormal PB bleeding. Its half-life is 5 to 7 days. The adverse effects include the reversible ovarian enlargement and cysts, hot flashes, abdominal and breast discomforts, depression, and blurring of vision. The dose is 50 milligrams for 5 days, starting on day 3 to 5 of menstrual cycle. Complications include multiple pregnancy and OHSS and hot flashes. So the question is, do we have an ideal stance? And the answer is no, we don't, because we get different effects from different drugs. So it's basically about what we want to achieve for that particular patient. For example, so just to remind you, the bazodoxifene is the only one that lowers hot flashes, while others cause hot flashes. The raloxifene and tamoxifen reduce breast cancer. And raloxifene is the only one that does not cause endometrial cancer. Raloxifene and bazodoxifene are good for osteoporosis, and for cardioprotection, raloxifene is an ideal drug. So with that being said, these are my references. Thank you.
Good morning. Thank you very much, Dr. Mkhize. We still got time, so I'm just going to spend 5 minutes, a few minutes just to say a few things, and then I'm going to take questions. So just going to start on the last under clomiphene. So as we know, and most of us would have been using clomiphene as a first-line drug for anovulated infertility. And I'm sure also most of us would know that. And now the aromatase inhibitor, letrozole, is the first line for anovulated infertility in PCOS women, ideally PCOS women with obesity. So if you do have a PCOS woman with obesity, it's probably better to go with the letrozole rather than clomiphene. So that's that. I thought I'd start with that. Then let's go to tamoxifen, then I'll do laloxifene. So in general, when it and then this is just maybe for the register, just to simplify. When it, I spoke to one of our colleagues in terms of the oncologist. What do you do? Do you have patients that you're actually using tamoxifen for prevention? The answer is very few. We hardly ever. So in clinical practice here, tamoxifen is generally used for adjuvant therapy, and not for, even though it's both naloxone and tamoxifen are registered for prevention of breast cancer. Locally, they are hardly ever used. Tamoxifen is used primarily as for adjuvant therapy in premenopausal women. If you have postmenopausal women with breast cancer, the adjuvant therapy to use is aromatase inhibitor. The aromatase inhibitors, and if you use aromatase inhibitors in premenopausal women, that patient needs to also undergo ovulation suppression, because aromatase inhibitors are ineffective in women that is still producing estrogen, because again, the mechanism of action is to preferably act by reducing the enzyme that So in other words, you can't be working against a factory that is continuously producing more of the drug that you're trying to inhibit. So they can be used in premenopausal women, aromatase inhibitors, but that woman also must undergo ovulation suppression. The ovulation suppression can either be in the form of drugs, that is, that will be the Zoladex. All right, so sometimes you will see patient, oncology patient on Zoladex, and generally, longer than we would use it. We tend to use, if you're using Zoladex for fibroids, we use it for 6 months. An oncology patient, they can use it up to 2 years because the risk benefits, it justifies the risk benefits. And then they would convert that patients, once they establish that she's best menopause, they can change over. So the ovarian suppression that patient will receive either with drug, radiotherapy, or surgery. Radiotherapy in these days is hardly ever used. So the patient will either undergo surgical oophorectomy or they'll go on drug ovarian suppression. So that's the approach to adjuvant therapy in breast cancer patient. Premenopausal tamoxifen, postmenopausal aromatase inhibitor. If you have a premenopausal woman that you want to use aromatase inhibitor, that woman also receive ovarian suppression. Okay, and then laloxifene of osteoporosis. So laloxifene for osteoporosis. Laloxifene is not used as a primary agent, either for prevention or treatment of osteoporosis, because it's inferior. So for prevention, it's inferior to HRT. For treatment, it's inferior to biphosphonates. And therefore, when we say second line, we don't mean it's better than the first line. It means it's used as an alternative to a patient that you can give first line therapy. Occasionally, if you, however, you do have a patient, postmenopausal patient with osteoporosis, but is also at risk for breast cancer, it's probably better, unless they have severe osteoporosis, in other words, osteoporosis with refractory. If they do not have severe osteoporosis, it's probably worth a discussion to say, you know, if that patient has independent risk for breast cancer, it's probably better to consider using laloxifene in that category of patient. So the category of patient that you would use laloxifene for, it's either the one that has primary independent risk factor for breast cancer plus osteoporosis, or alternatively, a patient that cannot tolerate biphosphonates. All right, I think those were my comments from my side. We'll now take questions and comments. We're going to start from local audiences, questions and comments, please. Yes,
thanks very much for the presentation. It was a very good presentation. I just want to know, what do we do with patients who have breast cancer who are on tamoxifen, who are asymptomatic, but have noted to have an thickened endometrium? So we know, like, the cutoff for sampling if someone on tamoxifen is now 8 millimeters compared to 5 millimeters that we normally use. But what if they're asymptomatic? What should we do?
Okay. I read the theory, and I will tell you, let me say what I do, but we'll probably go back to it. All right. And I think I've been influenced by commercial practice. You cannot sit with that patient and conclusively tell them that you do not have endometrial pre-cancerous lesion or cancerous lesion, and therefore you must sample that endometrium, even if they're asymptomatic. And that because, again, I would say I've been influenced by the commercial practice. So I think you can't, I don't see how you can sit with that patient and tell you, because you know that the drug it causes endometrial hyperplasia and can cause endometrial cancer, even though she's asymptomatic, because we do get patients that are referred, especially for commercial practice, where they have undergone imaging for some other reason, and they come and say this patient has endometrial. So you sit down and you say you are asymptomatic, all right, but this drug does cause, we do know that this drug causes endometrial hyperplasia. and therefore we would offer endometrial sampling. So the endometrial sampling you would offer, you either do, you can offer, it's appropriate to offer a papillary biopsy, or you can offer your first line endometrial sampling, meaning hysteroscopy and biopsy. So I think let's say like that, yeah, because even in the guidelines, I think they did when I was reading up to date, they seem to have that similar approach. So it's not just what I do, but when I was reading my up to date article on that, they seem to have suggest a similar approach.
Is that what the evidence showed, Dr. Mkhize?
Yes.
Because it says it's from commercial.
No, it is.
No, I just said that it's commercial plus evidence. It's not just, I did say it, sorry, Dr. Mkhize. Yeah, yes, so Dr. Mkhize, yes. So it's the article up to date have a similar approach for asymptomatic patient on tamoxifen with endometrial thickening. They suggest endometrial biopsy. Is there any other questions from the local audience or comments? And while we're waiting, do you have any questions or comments from the online? I don't see. No comments or questions from the online. We are almost at half past. All right. Thank you very much, everyone, for attending.
Thank you. Thank you.
Recording stopped.